I'm going to give a short overview of this white paper that we've written in collaboration with the University of Toronto. It's going to be a fairly whistle-stop tour through the contents, but hopefully it'll whet your appetite and stimulate discussion. As I said, this is a collaborative project between the Women's College Research Institute from the University of Toronto and Adaptive Lab. That collaboration brings together medical anthropological studies with the ideas from service and product design that Adaptive Lab brings to the project. Let's start with the definition of patients with complex needs. So patients with complex needs, as probably most of you in this room are aware, are patients with multiple chronic or long-term conditions, often compounded by psychosocial challenges. Why did we focus on this particular patient group? I'm sure most of you are already aware of the study. It was performed by the University of Toronto, but if we just look at the numbers here, we can see that in Ontario, the top 5% of high users account for 66% of healthcare spend. That's a staggering number, and I think anything we can do to improve the efficacy of the treatments that small proportion receive, that can reduce the healthcare spend or just improve the performance of that spend, will have significant impact. So how do we think we could go about looking at that problem? What we wanted to do in collaboration with the University of Toronto is look at how you could take established ideas from the world of service and product design, specifically design thinking and some of the ideas from behavioral psychology and behavioral design, and apply them to a new sector. As a company, we've applied these concepts to multiple different sectors, so to financial services, media and telco, and to retail, and seeing the success that you can have with applying these techniques to design problems. What we wanted to see is if these same types of ideas and concepts, the same methodology could be applied to identify interesting methods and ideas of how you could improve healthcare. We focused on 3 design methods. So I'm going to step through these all in a bit more detail and explain some of the problem, the theory that we use to inform our design process, the idea that kind of generated, and then at the end I'll go over some general findings and discussions. One other point to make here is that while these methods were all designed specifically with healthcare in mind, very similar approaches have been used for other problems that we've faced. And so these are essentially taking existing solutions and giving them a twist for healthcare. The first method we designed was a reward card game. The problem we were looking at here was people are really bad at connecting short-term behavior with long-term gains. There's a general approach in healthcare, which is if you tell patients what they should do, and that thing is a sensible thing to do, patients will act rationally and do that thing. I think there's a lot of evidence to show that that's not really the case. Some of the reasons are that new practices can be really difficult for people to incorporate into their existing routines, and the effort and complexity of those things makes that very challenging. Looking at this problem, what we thought was how could you help patients develop the habits that they need to support the kind of long-term gains that healthcare is after. We looked at some of the ideas from behavioral design, and here we just looked at the habit loop. So the habit loop is a very simple, kind of well-understood mechanism for forming habits. It takes a trigger, an action and a reward, and if you combine those elements together in the right format, they will help generate a habit. If you want to break a habit, then actually altering one of those things is also what you need to do. For this particular task, what we wanted to do was focus on that reward element. Now, if you look at rewards, there are a number of different types of reward that you can offer to someone. They don't just have to be monetary or some other form of financial gain. So we looked at the rewards identified in Nia Ayal's seminal book on designing habit-forming products. The book's called Hooked, and in the book he defines 3 different types of rewards. Rewards of the hunt, rewards of the tribe, and rewards of the self. What we wanted to do then was think about how you could use those different rewards to encourage the right types of behavior. We designed an exercise and ran the exercise within the team here to look at ways of using those different reward types to generate the types of behavior that you were looking for in healthcare. I won't go into details in the method here, but essentially by pairing different types of reward with different types of behavior. The second method was looking at designing for the remembering self. The problem here was that healthcare can have unavoidable negative experiences, pain, discomfort, embarrassment, etc. There are obviously avoidable negative experiences that can be designed out of the process, and wherever you can, you should look to design those elements out of the service. But for these types of experience where there's actually very little you can do, the question is, how can you improve the experience still for the patient? How can you improve the overall well-being? Now, there's some really interesting research around what happiness actually means, what well-being actually means. And so, looking at some of the ideas from Daniel Kahneman, he identifies two different types of self that help form happiness. The first is the experiencing self. This is the self that is living from minute to minute. In fact, some people say that the experiencing self only actually experiences a few seconds at a time. It's very much about being happy in that moment. The remembering self is the self that looks back on your life. It's a self that tells the stories about what's happened. And also, it's a decision maker. So actually, this is perhaps the most surprising thing about the remembering self, is that it's the entity that makes the decisions because it has the information based on those past experiences. So if you think about this, and actually if you think about individual experiences, so if you think about a holiday or a concert or any experience that you've kind of had recently, and you remember that experience, and you remember that compared with other experiences, that feeling you get about that past experience is all based on memory. And actually, if you think about how much time that thing took compared with the amount of memory you have, it's a very small amount. So if you can actually impact that memory, if you can make that memory more or less positive, you can actually improve someone's overall kind of experience of that past experience. How can you do that? Really simply, there are two ways of doing it. You can increase the positive memories and you can reduce the negative memories. Sounds simple, but how do you actually go about doing it? So we looked at three different ways. So repetition. Just by repeating a particular experience, you can make it more acute in memory. Similarly, if you just actually add reminders of that same experience, it can still make that thing stronger in your memory. Attention. So ensuring someone's full attention makes the memory stronger. Similarly, if you can distract someone from the experience that they're having, it will weaken that memory. Emotional impact. If there's something you really want someone to remember with a positive bent, one way of doing that is to pair that experience with a positive emotion. Similarly, if you want someone to lessen the memory of something for someone, what you need to do is actually just reduce the overall amount of emotion that's felt at that point in time. So again, the idea here was we designed a design method that would allow you to take individual moments in an experience, identify high and low points within that experience, so the points where people were felt very emotionally strongly or negatively, and then look at those different things, so attention, emotional impact, and look at different ways of increasing or decreasing the impact at those points in time. The third design method we looked at was assessing the cognitive load. So the problem here is that seeking medical attention and self-care requires patients to learn lots of new ideas. Often those new ideas are fairly complex and fairly novel to them. So actually something they haven't encountered before, and it's a lot of new information to take on. Unfortunately, they're also being asked to take on that new information and those new ideas at a point in time when they're least suited to it. So they're often can be emotional or distracted. To think about this problem, we looked at some of the ideas around cognitive resources. So here the idea is that cognitive resources are finite. You have one reserve of cognitive resources that are used for everything. They're used for memory, they're used for willpower, and they're used for decision making. And things that drain away that resource are when you have lots of options, when there's lots of complexity, when there's lots of novelty. When there's high emotional excitement, it's very difficult to take on new information. When you're mentally fatigued, so typically things that are easier to take on at the beginning of the day when you've got a full stack of cognitive resource at the end of the day. When there are environmental distractions, or when you're multitasking. And roughly speaking, these can be broken down into two main categories. So they're intrinsic factors. These are factors that are inherent to the problem at hand, the content that you're talking about. And then there are extraneous factors. So these are everything to do with, not to do with the actual thing you're trying to learn at the point in time, but everything that's happening around you that's impacting your ability to do that. So here the idea was to design a method that would allow you to identify points at which in a healthcare experience there were very high and low requirements on cognitive resources. So to do that, we just looked at a particular experience and put that into different scenarios, and then got the participants to actually score looking at those various elements that we just stepped through, the estimated cognitive resource that was required at each point of the process. So that's a very quick walkthrough of some of the principles we looked at and some of the design methods that we put together based on those. There is great scope to apply the principles of design thinking and behavioural design to the domain of healthcare. The methods that we trialled and prototyped showed great promise and helped identify some really interesting insights, we think, around some of those services. Just actually taking the approach of prototyping the methods and trying them with people meant that we were able to identify ways immediately of making those methods better, and some of those are highlighted in the white paper itself. But what's become very evident is actually the success of applying these approaches in a healthcare situation will be very much down to identifying the appropriate design problem. So not all problems are going to be best suited to taking these approaches. And then also to finding the relevant user population. So we tested this with adaptive lab staff. I think actually using these methods with healthcare staff, but also patients, will provide a lot more interesting insights that could be used to design better services. I think the final point here to mention is that we've only looked at a few concepts. So we outlined 3 in this presentation and in the white paper. There are very many more concepts that could be looked at to explore and use as stimulus in the design process. And we think there's a great scope to actually do that and to experiment with them. For us, I think the next step would be that we'd be keen to explore taking these approaches further with healthcare partners and patient groups. It would be great to kind of open up discussion to see what people think the scope there is to do that. And finally, I just wanted to actually finish by thanking the authors of the white paper, who both unfortunately couldn't be here today. So that's Lee Hayden, who's a medical anthropologist at the Women's College Research Institute in the University of Toronto, and Kat Matfield, the service designer who helped write the report. That's it.